Welcome to Bifurcation PCR Webinars 2025. Bifurcation Continuum has several modules, and for today we selected one of the most challenging lesion subsets, which is isolated ostial left circumflex stenosis. And our goals today is to learn how to evaluate left main 001 bifurcation lesion in terms of morphology and clinical relevance, to try to understand and discuss different treatment strategy for isolated ostial circ, and to learn how to optimize the result by use of intracoronary imaging and physiology. My name is Goran Stankovic, and I have a fantastic team of colleagues here. Here with me in studio is Maciej Lesiak from Poland, and we have connected Francesco Burzota from Italy and Fahim Jafari from Singapore. So please use the chat box to ask questions. I think you can help us by sharing your dilemmas, but also by sharing your experience. We will have fantastic 3 cases today, and we start with Francesco Burzota and his case. Francesco, take over.
Hello, everybody. Can you see me? Okay. So the case I want to share with you is a male, 50 years old, that had an important burden of risk factors for cardiovascular disease. And he had, since October 2019, a typical chest pain during emotional stresses. So the patient underwent a cardiovascular evaluation with an echo, which was normal, an exercise test that was positive due to this ST depression. So he underwent CT scan that showed diffuse atherosclerosis, non-significant distal left main lesions, and tight and soft ostial circumflex artery disease. So the coronary angiography is reported here. This is the right coronary artery showing a remarkable atherosclerosis. And here we have the left system. On the left panel, you see that there was a diffuse disease of the LAD without a clear stenosis. And on the right side, you see very well that there is tight ostial lesion on top of sure presence of atherosclerosis into the left main to LAD. So these are the main features here. We can discuss about the possibility to treat or not a patient like that on the basis of just coronary angiography. Anyway, what we learned in our experience is the fact that when the true Medina 001 lesion are often not the case in the case you go for imaging. So what we did in Rome was to perform a pre-PCI OCT assessment. And in doing this, we performed 2 pullback, one onto the LAD to left main axis and one on the other side. For LAD, it was very important because, as you can see in the long axis view, there was diffuse atherosclerosis, but clearly without a tight stenosis or a discrete stenosis. And into the top right panel, you may see the short axis view of the true osseum of the LAD that shows disease, but a lumen that is definitely preserved. And this is the other pullback we did that was on the circumflex, showing that there was diffuse atherosclerosis. The size of the vessel into the distality was around 3.0, and into the ostium there was a tight lesion causing this soft and eccentric stenosis with a 2.3 millimeter square area. So we can discuss how we can manage.
Yeah, thank you, Francesco. I have a question from Dr. Zaran. Thanks for the webinars. What are your options in ACS with culprit ostial circumflex without imaging? In this case, we have imaging, and which is a clear advantage. And I can try to share at least my personal perspective. in case of impossibility to use imaging, I try to anticipate plaque distribution based on angiography. So, for example, if we look at this lesion here, for me, I draw vessel contour first. So this is the vessel contour. And then this is the left main LAD. This is the LAD. And then I know that plaque is usually located in the lateral wall of bifurcation opposite from carina. So in my view, this is plaque at the ostium of the circ. And also there is some mild atherosclerotic burden in the left main. We know since the Oviedo paper that in 70% of ostial circ lesions, there is extension of disease inside the left main. And also, if there is disease of isolated LAD, more than 90% you have plaque extension inside the left main. So isolated ostial LAD or circ is usually disease of the distal left main as well. So the strategy, Maciej, you would like to join, you are very experienced. What do you think? What would be your strategy in this specific case? You saw the OCT, you saw diameters, really very narrow, very tight ostium of the circ. It's a large plaque burden, but not much calcium. So what would be your strategy?
Given the fact that the lesion does not look very complex, there is no diffuse disease in the circ, there is just an ostial lesion at the ostium of the circumflex artery, I think that simple stenting will be a great strategy here. Of course, there are, as always, more than one way to skin the cat. You can also do the drug-eluting balloon, or if the patient is not very symptomatic and you are not very experienced operator, you can even put the patient on pharmacotherapy. That's also an option. But I think in this relatively simple lesion touching only one artery, I think that one stent strategy will be the best in this scenario.
Yeah, in my view, question was related to ACS, and this is really ACS patient. This is my interpretation, so I know that part of the plaque goes inside the left main as well. So crossover stenting from left main into the circ, sized according to imaging in this case, or sized based on angiography if you don't have imaging, and then optimization of the result, especially at the ostium of the circ, where is the narrowing, but also proximal optimization inside the left main, and kissing to remove struts from the ostium of the circ. Let's go back to Francesco and see what was his strategy.
So, first of all, I want to say that on the basis of the imaging, all your pre-planning based on angiography only was confirmed, because you see definitely into the long axis view how the plaque looks to be exactly on the opposite of the carina. You can see it, into the long axis view. So regarding the strategy we discussed about, but what we can say is the fact that when you have a condition like that, you are in face of a bifurcation where there is a distribution of the disease that is now clear. And as you anticipated, to try to put the stent, in the case we go for stenting, bifurcation stenting, into the area where there is more plaque makes sense. To do this, what we can do is to apply all the things that we know for provisional, using the inverted provisional or inverted A according to the classification of the bifurcation stenting strategy. What does it mean? That we will implant the stent, as you mentioned, toward the circumflex from the left main. This will cover up the vast majority of the plaque, but we should accommodate the difference into the diameter, and we should be, for sure, open not to lose the LAD. So it is very important to go stepwise, but doing it in a very safe way. So what we did was first to predilate the ostium, the distal left main and the ostium with a non-compliant balloon. And we checked for the expansion of the balloon by the angiography. That also makes sense. Then we took the measure of the length for the landing zone, taking this image, you see contrast plus balloon, allowing to select the proper diameter of the stent. Other aspect is not diameter, but length. In terms of diameter, we recognize that the landing should be 3.0. So what we did was to deliver a 3.5 by 38, but doing it at low atmospheres, means at, the first atmospheres that allows you to have expansion. Why 3.5? Because we want to have a stent that accommodates very well the diameter of the left main that was around 4 or more. So then we selected to implant the stent, this cranial view, trying to cover up to the ostium since there was diffuse disease according to both angiography and imaging. The 3.5 was delivered at, you see, nominal pressure, not pushing too much. Then this is the image, very important when you have acute angulations. It is important because carina shift can jeopardize the flow into the LAD. You don't want to discover this after having performed POT. But here, applying this, let's say, advanced selection of the sites, we have been able to have flow preserved into the LAD. Then a semi-compliant 4.5 by 12 has been applied, 2 dilations, one close to the carina, one covering up to the ostium to be inflating the small amount of struts that were coming up into the aorta. Then the next step was to perform kissing. In order to have a better result, what is advisable is to go with a wire distal into the LAD. So we selected a third wire, and then we pulling it back, and we have been able to check by angiography the rewiring site. You may see into the angiography the fact that the radiopaque part of the rewiring tip, the guide wire, it is very close to the carina. Very important step for the efficacy of kissing balloon in this condition. Then what we did was to perform the kissing according to sequential kissing balloon with short non-compliant balloons. So the 2 balloons were placed on site, and then the first inflations were performed with 3.25 at very high atmospheres, isolated, and checking for the proper expansion, particularly at the ostium that we know often is very difficult to be managed. Then low pressure and prolonged inflation was done into the LAD with the other balloon that was uninflated to check for the expansion again, not to leave underexpanded struts. And then the kissing balloon inflation has been done. Thereafter, what we applied was with the same balloon a re-POT to correct the oval shape induction by the kissing balloon inflation. And this is the final angiographic results in cranial view showing the beautiful LAD preservation. And in particular, this is the caudal view showing that we really respected the original anatomy. There are no signs of dissections into the LAD, perfect flow over there, and good expansion of the stent. Since the procedure was based on OCT,
I don't want
we
to miss
performed
those questions.
Post-PCI OCT. You may see here the long axis view in the circumflex toward the left main, and you may see here the distal immediately to the stent no dissected circumflex that was less than 3.0. Here you have the stent that is at the proximal circumflex, very well expanded, circularly expanded after this non-compliant balloon inflation. And here you see that at the level of the polygon confluence, you can evaluate from the circumflex the fact that there are no stent struts in front of the LAD, so kissing was effective on the basis of distal rewiring, and also no dissection on the LAD ostium. Thereafter, the left main looked very well opposed stent struts, no problems. So we have been happy with this result. This was the clinical course, uneventful. During the hospitalization, the patient came after to return to normal life, and the CT scan performed 14 months thereafter showed the patency of the left main. You see also on the protrusion into the aorta that looks, acceptable. And what is interesting that we have been able to also explore the LAD ostium that was patent. The 5 years follow-up, since we are now at the start of 2025, never experienced angina. This colleague was a surgeon which is actually actively working, and the 5-year post-PCI ergometric tests were negative. Thank you for your attention.
Great case, Francesco. Thank you very much. We have several questions. Please answer very precisely and focused. Should we always extend from left main ostium to LCX, or we can extend from mid left main to LCX if we have good landing zone in the left main? Dr. Bal is asking, and it's also a question from Dr. Fattayeri. Is it necessary to cover the ostium of the left main if the lesion was only in the distal left main?
So anytime you are sure about the landing zone, the healthy landing zone in the left main, we may say we can also skip extending, but there was atherosclerosis, and at the end, diffuse atherosclerosis, at the end, the 4.5 millimeter diameter we reached was impossible to be reached on the basis of the original left main. So perfect. Here it was disease.
Second case, Dr. Tomsa, in case of left dominance, the strategy remained the same?
Yes. For us, yes.
Dr. Skoromna, great case. In case of LAD dissection, what strategy would you switch?
So we know that it is possible to fix this with both TAP and culotte. Honestly, in this acutely angulated left main, quite uncommon because it was 30 degrees. With the TAP, you may have too long protrusion, so probably culotte can be also a good option.
Mini culotte. Many questions about DCB. You know, these days DCB is super attractive for side branches in bifurcations. So let's start with Dr. Hashim Soaida. If we would do this case nowadays, will managing of ostial circ with DCB be a greater chance than Dr. Ahmedov? What about DCB? Because we more faced instant stenosis in ostial circ. Then there is another question from Dr. Zaran. Any consequence of putting stent in the place of torsion and extorsion of the base of the heart in the ostial circ position? What do you think? Would Dr. Ngo, would it be more sensible to prepare ostial with cutting scoring instead of NC balloon? So DCB and lesion preparation, cutting scoring?
Yes.
Okay.
So regarding the scoring, I think that it is a good option, but in this case, on the basis of imaging, the plaque looked really soft one, so no argument to more aggressive dilations with the dedicated device that are dedicated to calcium. Regarding the DCB, okay, so we can consider them. It is a novel opportunity we have, but we need the trials supporting the use in conditions where, like the ostial circumflex, where there is a really huge amount of myocardium supplied. So I think that it is a typical area where we need more data.
Okay, last question for you, Francesco, Dr. Acerbo. Which is the advantage to perform sequential kissing balloon before simultaneous kissing?
I think that there are strong advantages because with the sequential kissing, you have the possibility to accommodate and check for the expansion of the two vessels individually, and you can adjust the amount of pressure you are applying, and then the final kissing inflation that is associated with huge ischemia is just done for a few seconds in order to put the carina into the middle, because we know that when we go isolated dilations, we move the carina on the opposite side. So it is a way that really optimizes the post-dilation with the kissing balloon inflation benefits.
Thanks, Francesco. Really great case. Before switching to second case, Maciej, what do you think about Dr. Amber is asking again, what about cutting balloon prior to stenting to get good acute luminal gain and then better proper stent expansion? Would you consider it? Or?
Generally, for ostial lesions, this is a very good idea to cut with something more than just regular balloon. So cutting balloon, because there was no much calcium there, I think would be a great option, both for drug-eluting balloon and drug-eluting stent too. Yeah.
Yeah. Okay. Please keep sending questions.
Maybe short comment to a very important question, how much we should protrude from the circ to the left main. So simply, you don't have to cover the ostium of the left main, but the protrusion should not be shorter than the shorter spot balloon you have, because otherwise you will destroy the
even a few millimeters more to make sure that you fully oppose. Dr. Luna, why did you choose the stent the whole length of left main? Yeah, we answered already that. So many dilemmas about lesion preparation, DCB versus stenting, crossover, and then how long to extend inside the left main. But maybe we can be precise. Can you show us your case?
Yeah, of course. Quite different case. So please. So this is also, of course, a case of dominantly circumflex lesion. So we have 70-year-old gentleman with chronic coronary syndrome, with very diffuse disease and calcified plaques in LCX and chronic total occlusion of right coronary artery. So a few weeks before the patient came to my institution, the patient was admitted due to a non-ST elevation MI. When they found these lesions in CTO of right and occluded small marginal branch, they were able only to open with balloon without any possibility of putting a stent. You will know why in a few minutes. A couple of risk factors: hypertension, hypercholesterolemia, and type 2 diabetes. Nothing special as for lab findings, no troponin elevations, renal function okay, as well as LV function very good, 55% ejection fraction. Since the patient was unstable non-ST elevation a few weeks before, so he was on ticagrelor and aspirin and some medication for hypertension and high dosage of rosuvastatin, maximal dosage of rosuvastatin, ezetimibe, and dapagliflozin for his diabetes. So this is the baseline anatomy of the patient. So you can appreciate most of the disease is located in the circ. There is a very diffuse anatomy of the lesions, and if you look at the still frame, you see that we generally have two lesions in the proximal part and the mid part of the
Maybe we
marginal.
Join at the smart board, so we have already prepared.
Yes.
You need to take the arrow. Yeah,
okay.
One more.
One more.
And just stay aside so we can,
Yeah, so you saw already this, so we just, you can appreciate first that there is a very complex tortuosity of going from the left main to the circumflex, and the vessel is very heavily calcified. It could be very easily seen on the angiography. The other thing is even on angiography, you can tell what is the distribution of the plaque, and you see that most of the plaque is at the very ostium of the circ, touching left main. There is no significant disease on angiography in the left main. Also, LAD looks okay. But on top of this, everywhere is lots of calcium, and the second lesion here should be also, of course, treated. And what they did in the previous intervention, they just opened the small marginal branch with a small balloon, and that was everything that they could actually do. Yeah.
Yeah. So if I have to do this case, I see many obstacles. First, tortuosity, diffuse disease, angiographically seen large amount of plaque. So lesion preparation, imaging, at least in my view, is mandatory in order to make sure that you can, at least with guide extension, be able to deliver devices this time.
Definitely. Imaging is crucial here. I can tell you we wanted to start with imaging with IVUS, but we are not able to get down the catheter to this lesion. So before imaging, we had to prepare the lesion, and I will show you in my next slides how we did approach actually this anatomy. So are there any more questions regarding this patient?
Not so far. We have still questions for the first case, but that will come later. I don't want to interrupt your case, so please continue with your procedure.
Okay, so as I mentioned, we tried IVUS up front, but we are not able to deliver the catheter to the lesion, so we switched to the rota wire and started with 1.5 burr and regular rota drive, but you see that we got stuck with the wire. The wire didn't want to cross the first bend in the circumflex coronary artery, so we decided to increase our support, exchanging a regular rota wire into the extra support, and we downsized the burr to 1.25, and on the right-hand side of the slide, you can appreciate that this time the burr traveled distally, so we could ablate not only the proximal but also the distal lesion. Then we managed to predilate with NC 2.5 balloon because still there was an issue with delivering the IVUS catheter, so we predilated with 2.5 balloon, and then we were able to get down the IVUS. So you see a very calcified, like 270. Now you see the bifurcation, and the left main is also very calcified, but there is no significant stenosis in the left main.
I have to stop you because two very important questions for you are coming. Any concerns, Dr. Zaran is asking, any concerns about rota in severe tortuosity and acute coronary syndrome? And Dr. Papanicolaou, what about orbital atherectomy after imaging due to tortuosity?
Yeah, okay, so very good first question. There is a risk mostly related to tortuosity than to ACS because the patient was already a couple of weeks after. And you saw what happened when we switched from regular rota to extra support rota. Then we stretched the angulation of the vessel, and we easier went down with the rota burr. But you will see at the end of the procedure that with the first, on the regular wire, with first rota burr, actually we damaged a bit the vessel. And I will show you on IVUS with some creation of some cavity external to the stent. So this is very good question. If you have bendings, you have a lot of bends, a lot of angulations, you better switch to extra support wire because then you can do it more efficiently and safer. And the second question was?
Second, what about use of orbital?
Yeah, orbital can be done as well. We don't have so much experience with orbital. We do a lot of rota, more than 100 rota cases a year. I would not start with orbital in this particular anatomy when the lesion is really very tight and very angulated. That's why we chose ROTA.
Yeah, and one question which is probably related to every ostial circ. In isolated ostial circ, Dr. Ngo is asking, is there a role for physiological study which may reveal the indication for revascularization? In your case, I think there is no dilemma.
I think this is not the case. Good case for, yeah.
Super tight lesion, maybe more for Francesco, but we will come to Francesco.
Two super tight lesions.
Yeah. So after this imaging.
Okay, so just have a look now on the still frames of imaging. On the left-hand side, you see the calcium cracks created by the ROTA. Then at the very ostium of the circ, you see a calcified nodule, which also is very difficult to touch also with ablative techniques. Bifurcation, next image is the bifurcation. You see the LAD wire on the 12 o'clock, and you see that the LAD is widely open. And also for the left main, the minimal luminal area of this heavily calcified vessel is more than 10 millimeters square, so we don't need to touch left main. So we have a very calcified lesions, a calcified nodule at the ostium, and no significant stenosis in the LAD.
I need to stop you again because we have wonderful questions.
Okay.
So Arciletti is asking Federico, did you consider IVUS to assess ostial LAD before starting the procedure?
No, we started with ROTA. Yeah?
Dr. Baradi, is it advisable to have laser with 125, especially with angulated tortuous vessel, maybe laser?
Yeah, I don't have much experience with laser.
Yeah, me neither.
ROTA for this kind of lesions.
And Dr. Zaran, do you ever use cutting balloon in such cases?
Never. I would never start with cutting balloon. Maybe later, but you know, if you cannot get your IVUS catheter down the lesions, you're sure you will not be able to get it.
Definitely, yeah, because it's thicker and less flexible.
Yeah.
Okay, please continue.
Okay, so given the fact that we found those lesions in the circ and the calcified nodule, we decided to prepare more. So on top of rotational atherectomy, with the use of guide extension catheter, we managed to deliver the IVL balloon 2.5/12, and we used this balloon to do the shocks for the whole stretch of the vessels from the very distal part to the very proximal part. So it was, you know, a kind of rota shock PCI. Still having a guide extension in the circ, we managed to deploy the distal stent just to cover the distal lesion, 2.5/26 drug-eluting stent. And now we come to a very important point, because you have to imagine that it's around 2 hours already and a lot of contrast use. The patient was a little bit exhausted. Doctor could be fatigued, of course, the operator. And this is one of the reasons we chose maybe not the optimal bifurcation stenting strategy. So the operator chose just to nail the ostium. So you see now
to be honest, angulation is very favorable. You prepared lesion very well.
Yes.
There is also question, how did you probably distribute shockwave pulses across such long lesion?
Yeah, you have 120, so you can, you know, with using the guide extension, you can apply to most of this area.
And Martino is asking, using ROTA for ostial circ can be dangerous for left anterior descending ostium or not?
No, rather not, yeah.
I think branches are preserved while shaving.
You are breaking the calcium with bigger burr. You can even remove some plaque. So generally, it's safe to LAD.
Let's go back to precise nailing. Share some tips and tricks. How you position the markers of the stent?
Yeah, so
you need to know the stent.
Yeah, so maybe we go to the still frames, or we can switch to the
smart board. Yeah.
To the smart board. So here where we are, yeah. So this is where we are with positioning. Now it is very important to know what stent you are using, and we were using a Zion stent. Why? Because unlike other stents, there is no gap between balloon marker and the stent. So stent touches the marker or even overlaps the markers. So you see here the bifurcation is somewhere like this. I don't know where it doesn't work. Okay. So you have the, I don't know why this doesn't work. Yeah, okay.
Okay.
So you have a small protrusion, but after inflation of the balloon, you see that the marker went more proximally into the left main. Yeah. So with the Zion stent, if you're using a Zion stent, you can expect some protrusion, which of course should be confirmed and checked in imaging. Yeah. So we did the IBUS. Yeah. So you should be very precise, and in calcified lesions sometimes it's easier because the stent does not move. Yeah, with any beat of your heart, the stent can move. So in very soft lesions, it's very difficult to position precisely. Here it is quite okay, but of course missing the ostium would be another mistake. Yeah.
Yeah.
So there's always a trade-off between a risk of missing the ostium or the risk of some protrusion. So if we come back to the slides, you have again
the line showing the ostium.
And you see after inflation of the balloon, the stent comes a little bit more proximal. Yeah, so this is the result after. So we, of course, post-dilated, so implanted the stent. We post-dilated with 3-hole balloon, given the size of the vessel we found on the IBUS. And this is the final result. So the final result is, of course, as always on angiography, it looks great. What you can appreciate, and I will show you on IBUS, there is some, haziness behind the stent in the proximal part of the circumflex artery. Some, as if the lumen is enlarged, or kind of, ectatic or aneurysm creation. I will show you on the IBUS. So this is the IBUS analysis.
Can we come back to precise stenting? I like this question from Anastasia Skoromna very much. Have you checked simultaneous IBUS during the stent deployment? So you position IBUS towards the LAD, and then you pull back until you see it, and then deploy. I think that's one possible way to make sure that we don't...
Yeah, it could be possible, yes, because we use, in most of cases, 7 French catheter, so it could be, it's doable with this setup we had for this patient, but we didn't do this.
Yeah, sorry for interrupting. I thought it's important to share with our colleagues.
Of course, that's a good idea. So now you see the cross sections of the vessel still frames. And on the left-hand side, you have a bifurcation with the LAD. You see where the LAD wire is, the yellow arrow. And definitely you see some struts covering the ostium of the LAD. As for the stent expansion, very good, more than 5.5 for this not huge vessel. So this is, for the calcified lesion, is quite okay. And now look on the right-hand side, on the bottom image, there is something more than the stent. Behind the stent, there is some additional lumen of this vessel. So maybe I go back to so these are the images. So definitely, as you can see here, there are some struts of the LAD covering the LAD ostium. So there is definitely some protrusion of the stent. You can very nicely see it here. So this is the circumflex artery.
Yeah, and this is the floating struts in front of the ostium.
This is the bifurcation. This is LAD, and you see the struts coming here. And this is something that perhaps I think that this is the injury of the vessel
with rota.
done with the 1.5 burr
In the initial.
that couldn't get through. So this patient was very carefully observed after the procedure with a couple of echo scans, just transthoracic echo scans, just to be sure that there is no, fluid or tamponade there. But fortunately, it didn't happen.
Fantastic. Our guests are sharing tips and tricks. Dr. Tomsa, do you recommend PUF to confirm the level of protrusion during deployment of the stent? Another very simple way. And Dr. Jovic is asking, you have left all distal circ non-treated. Do you think it's not important? But you put the stent distally as well.
Yes.
In the circ.
Yeah.
So it was treated. Maybe we did.
Yeah,
not,
I showed. Of course, we did a lot of puffs during the procedure. Yeah, this is the easiest thing you can do, and you should do it. As I tell you, the point was not to miss the ostium. Before inflation of the balloon, it looked better. After inflation, definitely you saw that there's some more protrusion of the stent into the lumen of the left main. And maybe this is my last slide. This is again just delineated the circumflex, the takeoff of the LAD, and you can clearly see that there are some struts.
Some floating struts. We can still discuss that later on. I would like to invite now Dr. Jafari. Fahim, show us the third case and the third different way to treat isolated ostial circ.
Thank you, Goran, and thank you for the invitation to participate in this really outstanding conference. So I'm going to talk about a slightly different take on a difficult isolated ostial circumflex lesion. So this is somebody who we took care of back in 2016. At that time, he was a 62-year-old man, diabetes, hypertension, hyperlipidemia, and end-stage renal disease on peritoneal dialysis. And 3 years prior to that, he had presented with a non-STEMI and underwent DCB of an RPL. He was 59 at that time. And just to make the point, you can see on the left side, there was a tight right posterolateral branch lesion that was fixed with a 2.0, I think it was a Medtronic Falcon drug-coated balloon. It had just come out. The Bellow study had just come out, and we got a pretty good result. Now, at the time, the thing that's more important is that in 2013, sorry, I think if I could go back again. So at the time in 2013, if you look on the left side, the LAD was disease-free. And on the right side, you can see the ostial circumflex was quite okay. And that's important to keep that in mind. On the left side, you will see that the circumflex has a sort of a vertical takeoff in this view. And the ostium of the circ, you can see it quite well over there, is quite okay. Now, fast forward 3 years later, in 2016, he presents with another non-STEMI, this time with posterolateral changes. So we thought the circumflex was likely the culprit. And sure enough, when you look at his angiogram, on the left is 3 years prior, the circumflex ostium looks good. And on the right side, the circumflex ostium is hazy and quite severely diseased. And I'll show you a still image where you can see that compared to the left side 3 years prior, the circumflex ostium had clearly progressed. On the other hand, the LAD was quite okay. And as you can see, the circumflex coming up vertically on the left side in 2013 was quite okay. And on the right side, and I don't know if it's visible so well here, but the ostial circ was quite tight. And I will show you a still image to sort of make that point where you can see that the ostial circumflex was very tight. So here you have, and take it from me that the RPL was still open. So here I'm going to just put it to the panel. What do you do? It's an isolated ostial circumflex lesion, non-STEMI, the LAD, and the right coronary artery are okay. So what do? You treat it medically, stent the ostial circ, do a complex bifurcation stent, or do you do something else? So I'll put it to the panel.
Yeah, thank you very much, Fahim. I try to reflect on your case here, just showing clearly very tight disease at the ostium of the circ. Also, some disease already present at the ostium of the LAD, but definitely non-significant. And in the other projection, clearly disease of the circumflex ostium. It's a long vessel, so diameter is probably not small. There is linear correlation between the length and diameter. So if I have to answer your question, you can, except for maybe medical treatment if patient is in acute coronary syndrome, all the rest is feasible. Stent precisely the ostium, less likely. Stent from left main, LAD and circ. Stent from left main into the circ definitely would be my choice. I don't know, Maciej, what would be yours?
Again, the same as in the first case, the lesion does not look very complex, so the simple stenting with inverted provisional technique, I think, will do the job very, very well. But of course, there are other solutions as well. Yeah.
Let's see what Fahim decided to do. Fahim, what was your selection?
Right. So if we go back to the slides, so at this point, basically all options were on the table for me. We decided that we will try a drug-coated balloon strategy if we can get away with it, but we're prepared to do anything from just left main to circumflex stenting to even something more complicated if the LAD sort of went down because as Goran pointed out, the ostial LAD was not completely normal. So we went up with a 7 French guide, prepared to do everything. And I started off with taking a FlexStorm 3010 cutting balloon and inflated the circumflex at just 6 atmospheres for about 40 or 60 seconds, which it tolerated quite well. Moving forward, this is what it looked like after. So we thought this was a fairly reasonable post-cutting balloon result. No dissection, a residual that's well below 40%, probably around 30%. And we thought that this was an acceptable result. And we went ahead and then treated this with a 275 15 by 15 paclitaxel coated drug-coated balloon. They deployed it at 6 atmospheres for 60 seconds. And again, the patient tolerated it quite well, considering that the balloon was sort of partially in the left main. And this is the final result that we got at the end of it. Not the most perfect result, but we thought was reasonably acceptable in the sense that you look at the ostial circ in the left panel, a slight residual, but still okay. And on the right side, you can see the ostial circumflex a bit hazy, but otherwise quite all right. And just to sort of, make the point, on the left side in 2013, the ostial circumflex was good. You have the AP caudal shots on the top and the AP cranial shots on the bottom. And then in 2016, 3 years later, the ostial circ with a tight lesion and post-DC cutting balloon and DCB angioplasty looked acceptably well. And I thought that we would take this as a win and see how we did. I have to sort of also mention at this point that we at that time did not image. We now would have imaged this in 2025, but back in 2016, we weren't doing that much imaging. So we did not take any intracoronary imaging studies. Now, you fast forward 5 years later, and he did very well. No symptoms, active, doing everything. And in 2021, he shows up with chest pain, which was sort of in the sort of intermediate probability. Some typical features, some atypical features. EKG, no acute changes. Biomarkers negative. Ejection fraction normal. And we went ahead and sort of took a look. And the LAD, you can see, has minor diffuse disease. And just for out of interest, we put a pressure wire, and it's all good. You can see in the upper left panel, the ostial circumflex is taking off vertically from the left main, and it looks pretty okay. And in the caudal shots, you can see that the ostial circumflex actually looked pretty good, all things considered. But just to be very certain, because this was at the end of the day something that we were concerned about, we went ahead and did an OCT imaging, and this is just showing this to you in the still frames. We went ahead and did an OCT image of the circumflex. And on the left-hand panel, you can see just the ostial portion of the circumflex looked pretty okay. The minimal luminal area in the circumflex was 4.5 millimeters square with a little bit of a calcific nodule, and that's why it still looked a bit hazy. We put a pressure wire down the circumflex, and the FFR was 0.92. Essentially, this is sort of taking you to the sequence, going from 2013 all the way on the left to his PCI in the middle in 2016, and then 5 years later on angiography, as well as physiology and anatomy, the ostial circumflex still looked pretty reasonably good. And at this point, we just continued to treat him medically. And just off note, the RPL that was fixed, you saw the earlier images on the left in 2013, even in 2021, that RPL actually looked pretty good. So this is just to highlight a case that where one of the options, although not the only option, is to actually address the circumflex in a more with a different approach using a drug-coated balloon. And certainly in this case, we got a fairly robust long-term result, and happy to answer any questions.
Yeah, perfect. I tried to interrupt you in the beginning, saying that our audience really anticipated your selection, because something else, most probably DCB, was elected by 40% of people who voted. Stenting of the left main LAD and circ, so complex stented, 1/3, 34%. Precise stenting of the circ, 27%, and 0% to treat medically. So acute coronary syndrome, and I just would like to continue asking you about today's selection. It's very attractive option, putting a drug that definitely favorably affected also the ostium of the LAD. I think at follow-up in 21, LAD looks better than in 2016. This could be very promising for selected cases. What are your cases? Help our audience understand what are the cases.
I think the case is obviously isolated circumflex, where the patient, ideally has a soft lesion that would respond well to a cutting balloon. Although I think that if you have a calcific lesion, and now with IVL, we seem to be getting pretty good osteal.
I need some help with questions.
So those would be the main sort of subset of patients where I would offer this. You have to understand the pitfalls, and the biggest pitfall is that the result can be unpredictable. And so if you don't get a good enough balloon angioplasty result, you should be prepared to go with all the other options that the previous two excellent cases were presented. So I think it's reasonable to go with the drug-coated balloon strategy, but with the option to change if the result isn't what you like.
So you didn't perform imaging, but the fact that you managed to deliver a cutting balloon without any problem into the ostial circ lesion, that's a symptom that this lesion could not be very severely calcified. And I think that's one of the prerequisites where in what kind of lesions what kind of anatomy drug-eluting balloon can work at the ostium. Otherwise, if the ostium is severely calcified or the ostium is very fibrotic, drug-eluting balloon may not work because some mechanical purposes of the characteristic of this area. Yeah?
I agree with that, and a flextome is a very inflexible balloon. The Wolverine is a lot better. I will say, though, that when the ostial circumflex is heavily calcified, they also don't do well with stents. They end up coming back with restenosis, and that is sort of the bane of our existence. So more and more, we have actually elected to, even if it's a bifurcation lesion, we've elected to DCB the ostial circ and, stent across. Just because of the fact that the ostial circ tends to be very, very resistant and comes back.
Another that should be also stressed is that you well prepared the lesion. So using a cutting balloon in a soft lesion before applying drugs from the balloon is crucial here, because you facilitate the drug delivery deep into the tissue, and maybe this is one of the reasons the long-term result was so good, because actually the lesion looked better after 5 years than just after the procedure with some haziness due to dissections, etc. I see Goran still can take some questions.
Yeah, I'm struggling with questions because suddenly disappeared. What is the future of bioresorbable stents in circumflex ostium? This has nothing to do with this case. That's the only one I can have.
Shortly, we don't know, and definitely not the technique like nailing the ostium, because we have a very bad experience with previous bioresorbable scaffolds, because remember that what will protrude into the left main and LAD is a very thick strut, very strict scaffold. Yeah? So then the risk of thrombosis, left main thrombosis, is very high. So I cannot recommend using thick strut stent or scaffold for nailing the ostium.
Definitely. But we have enough time. I just would like to share one case, which is actually, in addition to your case, describing pitfall. It's actually unintended floating, which is extreme. And this is the case that we published in Neurointervention in 2023. It's a clinical case, and it's very important, even if at the baseline you don't use imaging and you have impression that you really precisely stent. This patient came back after precise ostial circumflex stenting with acute coronary syndrome and disease progression also at the ostium of the LAD. So that's clinical consequence in some of the cases, not always. And there are two different options that I wanted to share with our colleagues. So if you have floating struts, whether it's floating from the ostium of the LAD or from the ostium of the circ, there are two different approaches. In this case, what we did, we actually used OCT to make sure that we go with wire outside of the floating struts, and then we used big balloon to crush the protruding segment, and we converted these floating struts into decay crush case. So after crushing, you rewire, you do first kiss, then stent towards the LAD, second kiss, and final pot, and final OCT with good coverage. The other option is to try again to use imaging, preferably OCT, to make sure that with wire, you wire inside the stent, and then you do kissing, you convert to decay culotte. So either decay crush or decay culotte could be the options, depends from case to case. In this case, if you have a late comer with clinical syndrome, we thought anatomy is more favorable. We had to cover also the ostium of the LAD, so we converted into the decay crush.
Maybe one word of caution. You were very lucky and your result was great, confirmed in OCT, but keep in mind that if you choose to do decay crush in a stent that was implanted years or months or years before, then the stent is covered with tissue. And if you crush the stent, which is already covered at least partially with a tissue in the left main, then rewiring might be really a challenge, to get the wire down to the circ. So if the protrusion is big enough to do culotte or decay culotte, then I would prefer doing culotte. Otherwise, you manage to pass above the struts to the LAD, and then of course you can do the crush, but keep in mind that recrossing may be more difficult than usual.
Yeah, so I have my questions back. Our old friend Bogdar Janusz is asking, do you recommend any of imaging as follow-up protocol after cutting plus DCB? And if you do, Fahim, in what period? Thank you. Fahim, are you with us?
Yes, Goran. We don't routinely image if the vessel is open and it looks good angiographically. I think that's good enough. In this particular case, we just imaged because we were curious to see what that haziness was, and you can see that there was a little bit of calcium up there that had developed in the subsequent years. But I think routine imaging, if it looks okay, looks patent, post DCB, we don't tend to do it.
Yeah, Dr. Vigo is asking, do you think calcium is a live tissue which may be better treated with DCB? Fahim, it's for you. If it's calcified, you don't recommend DCB, or you do?
Actually, yes and no. I think if it's calcified, you try to open it up, and if you don't get a good result in you not able to open it up, actually we favor DCB because when you put a stent, they all come back, at least in our experience. On the other hand, if you get a good result, you're able to open it up, then all options are on the table. You can still DCB it, or you can just go ahead and
I
stent.
think the crucial thing is preparation. If you obtain a stent-like result after big Barota and cutting or high-pressure balloon, then you just deliver the drug to the vessel, and this is okay. Otherwise, you better stent.
I need one question to all of you. In what percentage of PCI you use imaging? That was question from the beginning. Maciej?
Generally, 30% of all PCI, but complex PCI, left main, we do 100%. Yeah?
Francesco? In what
We are in
percentage?
the same line. I think we are not systematically using imaging, but we are using it more and more when there are complex lesions. So the concept for us is in any condition where we are uncertain about the angiography, we perform. And in the cases like left main, where we know that imperfections can be linked with adverse clinical outcome directly, we use imaging.
Fantastic. Fahim?
I think in our lab, it's about 80% now. We image practically everything.
Fantastic. We are more in the range of Maciej, even less in general cases. So this was fantastic. Thank you, all of you. Really fantastic cases, excellent discussion. I thank our participants for phenomenal questions. We learned from you a lot today. Thank you very much for joining. And of course, I would like to thank Medtronic for making this possible, because different strategies are applicable for isolated ostial circ. We don't know which one is the best. We still have to learn. And webinars like this one are excellent way to learn from other experiences. Thank you very much, and I wish you a good day.
Thank you.